looking for the literature for the frequency of nerve damage in the total hip arthroplasty, then we can recognize that the rate of this damage is fortunately very low. It's below 1%. So we can say a nerve damage is very seldom. Sensible deficits are more than motoric problems, and the big luck is that the nerves have a regeneration capacity. What we have for nerves around the hip, that is the lateral femoral cutaneous nerve, it's a femoral nerve, the sciatic nerve, obturator nerve, and the supragluteal nerve. Here's some overview from an American review about frequency of nerve damage. So they used the posterior approach as the standard approach, so that's the reason the sciatic nerve was the most common nerve which was damaged, followed by the femoral nerve. But this depends on, of course, on the approach. Also, specific risks are the surgical time, the number of previous surgery, the leg length discrepancy, intraoperative changing, multiple changing of position as a risk factor, ossification, dysplastic hips, and female gender. And we have a lot of unspecific risk factors where you can see in the literature that patients with these conditions have a higher risk for nerve damage than without. What we have for nerves that we have already explained, and we have also said that this is dependency of the approach. So usually we have four approach, the anterior, the anterolateral, the lateral, and the posterior approach, and dependency of the approach, specific nerves are or may be involved. The lateral femoral cutaneous nerve is very often affected when we use an anterior approach. Between 14 and 80% are signs of a nerve damage of this lateral femoral nerve. This is a sensitive deficit on the lateral side of the thigh. And the reason is we have a very variable anatomical course of this nerve. So if you make a skin incision, we cannot be sure where the nerve is exactly located, and that's the reason for the high rate of damage. The femoral nerve is protected by the iliopsoas muscle and the anterior acetabular rim. And the most common risk of damage is the unprecise placement of the hook on the anterior rim. So you can see it here. If you place the hook into the muscle belly, then you have a risk to damage the nerve. And what you should do is place the hook as high, as cranially as possible. There is a protection area here on this side. As caudally you are, the risk is as higher to damage this nerve. In revision cases, there's an additional problem because often we have a reduced anterior wall, and then we have only the muscle as a protection, and then we can affect the nerve by reaming, by setting hooks, or by cement. The femoral nerve is the muscle which is innervated as the quadriceps femoris muscle, and the patient explained after a femoral nerve damage giving a wave phenomenon, restriction in climbing stairs and single leg stand, and they have problems in active extension of the knee, which is our clinical test. And the sciatic nerve is often affected by the dorsal approach, and we have a tibial and peroneal portion of this nerve. While the tibial portion is very medial, the peroneal portion is laterally, and that's often the reason we have this foot drop problem when we damage this nerve. Here also the risk is an unprecise placement of the hook on the posterior rim, and the same in a revision. We have problems with the reduced posterior wall. We have sometimes lots of scar tissue, and so we can, by the preparation or by reaming, placing the hook or cement, affect. Here you can see this is the close relation between the femoral and the sciatic nerve when we prepare our acetabula. We should know, if you use the posterior approach, then we always have to internal rotate the hip so that the distance between our femoral neck and the sciatic nerve is very far. And if you have the problem, then the patient needs this foot drop brace so that he can walk without stumbling. The lateral approach, there's some literature. when we use the lateral approach, which is quite common in Europe, then we could be a problem with the superior gluteal nerve, and there's some evidence that in 50% during the surgery, the nerve is affected, but they looked after 6 months, only 7.5% showed some electromyographic signs, and after 12 months, only 1.5% of the patients had a positive Trendelenburg sign. If we damage this nerve, then we see this huge fatty atrophy of the gluteus medius muscle, and then we have the problem with the positive Trendelenburg sign, and the patient is not good or not able to walk without scratches. And we know that we have this safe zone, that means 5 centimeters from the tip of the crater trough. Here we are safe, but more than 5 centimeters we have a higher risk to damage this nerve. There are some additional patients or some patients with a higher risk for a nerve damage. These are patients with a post-traumatic hip, with a Girdlestone hip, with a DDH, and especially with a high hip center, with previous surgeries, and patients when we replace the hip in a case of ankylosis. So all these patients have a higher risk to damage some nerves. And here is a patient with a DDH, with a high hip center, and if you implant a new prosthesis and rebuild a physiological hip center, then we know that it's only allowed to prolong, to lengthening only until 4 centimeters. The risk more than 4 centimeters is increasing for nerve damage. If you have more than 4 centimeters, then we have to do or perform this shortening osteotomy, as you can see here. This prevents nerve problems. But from the literature, they found here a study, 508 patients with a dysplasia, and they found only in 8 patients a nerve palsy. And interesting, that was independent from the lengthening in centimeter. So they found no statistical correlation, interesting, for the amount of lengthening and the incidence of nerve damage, but the surgeon always, when a nerve damage occurs, they say there were previous surgery, there was a severe deformity, and some considerable flexion deformities. So we remember 4 centimeters and some cofactors. Patients with this have a higher risk of a nerve damage. If you have this problem after treatment of a DDH patient with a leg lengthening, and he has a nerve damage and signs of sensitive motoric deficits, then you have to treat very acute after the patient awake from the narcosis. So you have to go back into operation theater, remove the stem, and relax the whole situation so the nerve may be recover better. Diagnosis and therapy. Post-op control means you have to control your motoric and sensitivity in every patient after operation, stop the regional anesthesia, and if you have a problem or you think there could be some problems, then think about a CT scan or an MRI scan to look for the nerve and some hematoma. Do a neurological and neurophysical examination. And the therapy means either revision or do a relaxing position of the patient. There's some evidence, but not high evidence, to treat with vitamins, with dexamethasone, and perform some electrostimulation. But unfortunately, this is not there. The literature shows no big evidence. And the prognosis is, if you have a partial damage, that is better than a complete damage. The femoral nerve problems are better in regeneration than sciatic injuries, and sensible or motoric problems are a better prognosis than sensible and motoric problems. And if the patient has a lack of comorbidities, it's also better. And if the patient shows an early regeneration, for example, with a fast sensibilization regeneration, then this is also a good prognosis. Vessel injuries, so in primary, between also under 1% and revision much more. And the most vessels which are injured is the femoral vein and artery and the external iliac artery. And there are some direct damage causes like reaming, screws, using hooks or removal of osteophytes, and we have indirect damage problems with positioning, distension, and thermal injuries from the cement. Problem in revision arthroplasty is the patient has multiple prior surgeries, we have cicatriciation, we have restricted orientation, missing of typical anatomical landmarks, and we have a bony defect, so missing protection structures for our vessels, and of course micrated implants in cement could also be a problem, as you can see here. Be carefully when you remove this, and with this you should not do this operation before a CT scan and without a vascular surgeon. Severe bony defects and micrated implants, what you should not do is ream, only ream in a diverse direction. You have also to remember that there is no bony structure which saves our vessels, so you can injure the vessels very easily. Here you can see it, how close it. Here is the protection structure, the bone in a Paprosky 1 defect. In a Paprosky 3, you haven't anymore the bone for protection. Wasilewski et al. Reported about a safe zone. You can find this safe zone for a safe placement of screws without or avoiding injured vessels. You have to throw a line from the anterior suprailiac spine to the center and a perpendicular. Then you have 4 quadrants, and in this posterior suprailiac quadrant you should screw your cup. That is the most safe area to avoid vascular problems. This should not happen. Here's a high risk. And time of detection of the vessels are only 25% are intraoperatively, and the rest of this are postoperatively. And acute intraoperative bleeding, the most common sign is a drop in blood pressure during screwing or reaming, and then you have an acute problem. What you do there is extension your approach for better looking for the bleeding, or use an additional approach. Using vascular surgery instruments, call a vascular surgeon, call the most experienced orthopedic surgeon in your department, and inform your anesthetist it's an emergency case, and ensure enough blood supply. And postoperatively, you have to control the pulses, the blood parameter, the limb diameter, and all these factors. And if the patient has an unclear high hemoglobin decrease postoperatively in connection with pain and weakness, then you have to perform angiography or something of this to look for bleeding. And we perform this cardiovascular intervention because you can look for a bleeding, in the same session you can treat it by coiling or clipping. And if there's a bigger problem, then you have to do a vascular intervention to end-to-end or patch or graft. Thank you for your attention.